That was a fantastic session, and I know we're about to go into another really thought-provoking session, but another change of gear. I'm absolutely delighted to be welcoming Professor Chris Whitty to the stage, who's going to be talking about quality of life for older people and some patterns of disease, and again, I think setting up a range of challenges for all of us. Chris Whitty is known to everybody in this room. I really don't have to introduce him. So I'm not going to go through the very long list of accolades that I could go through. But I think one of the things I will always remember, and many people at this summit will remember, is he was here 2 years ago. Well, he was here in 2020, a few weeks before the pandemic became really acknowledged and understood in this country, and certainly a few weeks before we went into our first lockdown. And I have a really strong visual imagery of Chris trying to talk about something other than the pandemic, and a huge group of journalists over there waiting to talk to him about it. And it was an extraordinary event, and probably the last large event that many of us went to before the pandemic shut us down. Anyway, not to talk about COVID, I'm very happy to welcome Chris to the stage.
Thanks. Thank you very much indeed. Some of you may have read a report I did on older people. I'm not going to just précis that, but I'm going to pick up some of the points. If you haven't read it, I didn't write most of it, and it's excellent. At least get through the first 2 chapters, because I think some of the points that I'm making here are expanded on by really good colleagues from around the UK. The last 170 years have been the most transformational in medicine. They've been an extraordinary situation where essentially up to about the 1850s, mortality stayed really pretty flat everywhere, almost no changes. Then you saw this astonishing improvement in life expectancy, starting in the wealthiest countries, but now really occurring everywhere. And that is continuing. Child mortality in Africa, for example, is dropping extremely rapidly. But we're coming to the end of this arc, and that's part of the reason for this talk. This particular upswing is going to slow down and going to top off, in my view, over the next decades, and it's going to leave us with some very different challenges to the ones we've had previously. If we look over the last zero in the last decade, everywhere in Europe, and indeed most high-income countries, there's been a stagnation in change in mortality, and there's a clear inflection point. This wasn't just a natural biological phenomenon. Every country blames it on its own individual policies. It appears to be everywhere. We do want to just note 2 other things on that, though. The first of which is the big dip that's been caused by COVID. That'll take a while to wash through the system. But the other thing is the fact that the UK has been steadily drifting down the leaderboard since the 1980s. This isn't a step change. This has been a gradual process, not a long way from everyone else, but we've moved from the middle of the pack to quite near the bottom of the pack. This is an economist graph, and I think a rather stark one. Now, over that time, of course, that has led to a very substantial shift in the pattern of the age structure of the population. And that, of course, means that both the health and care needs have changed radically and largely in ways that were not planned for. So if we went back 100 years ago, we had a population pyramid pretty similar to Nigeria's today. The one that I think I really want to pull out is the 1950s. That's around the time of the foundation of the NHS. This is what the health and social care systems were essentially designed to deal with, was that population pyramid. Quite a large working age population, fairly large number of children, very small number of elderly. That is really what the whole of the Beveridge approach, the big changes that happened both during and after the war were designed for. Now we have a very different population pyramid, and that's going to become more stark if you look at the projections as we go out over the next decades. A much higher proportion of people are going to be beyond working age, and a lot of them are going to be in what by any standards is old age. And this is happening everywhere in the world, and this is a triumph, and I want to be really clear. I see this as a very positive thing. And if you look at, for example, any country not actively at war, we actually now have virtually every country in Africa has as good a healthcare outcome in terms of longevity as we had when the NHS was founded. So this is a great step forward. There are, however, some challenges coming up which we're going to have to be quite serious about. The population in the UK is expanding, but actually the population of working age is essentially static. The expansion is almost entirely occurring in people who are in their late 60s, 70s, or 80s or above, as these graphs demonstrate. So you've got a very static working age population and a rising older age population, children staying again pretty static. And the implications of this for the rest of this century are really clear. And unlike economic projections, demographic projections are extraordinarily stable. Almost everybody who's going to be 75 at the turn of this century is already born. So this is not a guess. These are the age support ratios going out to the end of the century. We're at the point where the fan out tends to happen. If you look at that and then say, well, the answer to this is just employ more people, this becomes clearly an impossible ask. So we've got an increasing proportion of older people and a decreasing proportion of working age people, which will steadily diverge over the rest of the century. And it's not just the UK. And the reason I want to make this point is our solution to not planning for things has to date, when it comes to workforce, been import them from elsewhere. And we've been able to do that because other countries have had a much more advantageous age support ratio and a very strong economic gradient and/or a very strong economic gradient, making it attractive to come to the UK. Actually, many of our continental neighbours, for example, are going to have a much harder landing demographically, where they will transition from a high proportion of the population being working age to a much smaller one over a very small number of years. There will be very stiff competition for social care workers, nurses, doctors, technical people, AI, to go back to the last thing. There's going to be a very considerable competition, and this will make the ability just simply to import in because you're sort of making up for errors you've made previously almost impossible to do, in my view. And to be clear, I want, before you get a bit gloomy, I'm going through setting up the problem first and then going to talk about what I think we should do about it. This is not all just, it's all terrible, but this one's also an it's all terrible slide. If you look at both absolute, but more importantly, proportion of GNI that we are currently spending and projected to spend on healthcare out for the next decades, it's going in only in one direction. These are OBR projections, and as you can see, the proportion, you saw the budget yesterday, that you saw the difficulties that the Treasury has funding in the current situation. If we move out from a situation where about 7% of GNI is going to health to one where about 13% is, that is clearly going to be an even greater challenge. So if that is what happens, and that's an if in my view, not a definite, we have some serious problems ahead of us. People always say, well, a lot of this is to do with people's increased propensity to consume on health, and some of it is. But actually, if you age adjust, and these are IFS data, if you age adjust, actually, the proportion spent has not increased by anywhere near the same amount. So once you population adjust and age adjust, and the reason I'm making that point is, since our population is older, this is inexorably going to continue if we have people continuing with the same healthcare needs as they currently do, dealt with in the same way. But that is, in my view, under our control, potentially. Now moving on to that's a bit of sort of time series, moving on to a bit of the geography of this. And important to be really clear that there are two really big drivers of the patterns of disease in the UK. One is deprivation, inequality, poverty, call it what you will, but we all mean the same thing. And the map, as everybody is aware in this room is aware, of under 75 mortality, which is a proxy for very poor health, and the map of deprivation are essentially the same map. Now, depressingly, if I project the map on the left here, is the map of infant mortality up to 1 year in 1860. And I'm showing this to show how deeply entrenched some of the inequalities and ill health outcomes are. This is going back, right back over 100 years. So that on the left, COVID on the right, just to show infectious diseases follow these patterns. So there's a map of deprivation-associated disease. I want you to hold that in your mind and then look at this map. This is the map of older age now on the left, and on the right where it will be, this is not a possibility, it will be by the time we get to the 2040s, and they are completely different maps. There is some overlap, but the reason I'm making that point is the big increases in health driven by old age are going to occur in quite different places to the areas which are driven by deprivation, and they will also, as I'll come on to, lead to different disease patterns. And we need to plan for that rather than assume that every part of the country has got the same needs, because that is not the reality now, and it will become even less the reality as we move forward in time. And this is really because the model in the UK is that people move into cities, usually around 18 for work or study, and they leave typically straight after that, after their second child or when they retire. Various other points as well, but that's the British model. It doesn't have to be like that. In Canada, people move in as they grow older to cities, but that's what we do. And what that leaves, therefore, is large areas of the country which have got not only large populations of older people, but small populations of younger people who can be care workers, can be doctors, can be nurses in those areas. So this mismatch is going to become increasingly problematic. And if we go back to this point I was making about age support ratios, the age support ratios in the towns are actually going to remain pretty well static for at least the predictable future. So I'm not worried there will be a new problem on this in London, Manchester or Newcastle. I do worry that there will be a new problem with this in rural southwest, in coastal towns, in the rural north. These are where the big challenges are going to occur, and you've also got transport problems and many other issues with that. Now, some of the implications of this are in essentially the medical sphere. So just to take two examples of a disease group which are around younger age, sexually transmitted infections. You can get them when you're older, but they're much more likely to be earlier in age. And dementia, almost all old age. You can get it when you're younger, but rarely. Those are now really segregating to completely different parts of the country. It was already the case. This is going to become increasingly so. So you don't want to be worrying about your stroke units in the areas where the predominant diseases are diseases of younger people, and you only probably need to have a relatively limited STI service where most people are in older age, although you need to have provision for all enjoyments of life all the way through the life course, to be clear. But most diseases are a combination of those two. And this is from a coronary heart disease. I've taken this from a report I did on coastal towns, and I think it's pretty stark. It's essentially a combination of places which are areas of poverty and deprivation and places that are areas of high concentrations of older people. There's a missing middle in the middle, and if you project all the big universities onto that missing middle, you'll see why sometimes, in my view, some of the research is not really thinking about the problems of the periphery where the growth areas are going to be. And this is true also for mental as well as physical health. There is a big geographical disparity in this. There's a significant socioeconomic disparity, and there's also a changing pattern of mental ill health, which we do not yet fully understand, but it's been very stark, probably accelerated by, but not caused by, what happened during COVID and the lockdown and all the things that went with that. And finally, whilst I'm on the gloomy section, before I move on to, okay, what's next, the absolute period in ill health, and these are the people who will be asking for NHS services in due course needing social care services, has increased, not just proportionately, but in absolute numbers of years over the last decades. So that's a set of problems, and we need to face them very squarely. They're happening, they're not guesswork. This is where we are now and where we are heading. So now I'd like to move on to some of the things I think we should do about this. Firstly, I'd like to start with multimorbidity, multiple chronic diseases, but that doesn't capture the totality of it, both physical and mental. Most people here will be well aware that people tend to move from a state of having no diseases to several diseases over quite a short period of time, actually. Diseases cluster in individual people, either because they've got a common risk factor, something like smoking, particular genetic predisposition, lifestyle factors, or because of the societal situation in which they find themselves. Broadly, people living in deprivation up to the age of about mid-70s, early 80s, the big driver of this is going to be deprivation in terms of who gets it first. Once you get to about 80, it doesn't matter. Well, that deprivation is just age that drives it. And from then on, it's really an age phenomenon. Why am I highlighting this? For two reasons. Firstly, we need to slow this process down as far as we can, and that's about delaying disease, which I'll come back to several times. Secondly, we need to reformat the way we're going in medicine. I very strongly think that we have moved in the wrong direction by allowing people to specialise, which is a good thing, but then in doing so to lose their general skills, which is a bad thing. We should be maintaining generalist skills for the longest possible period in every discipline. We need to reformulate the way we think about research, so we think just as much about how diseases interact in one person as we do on the bench to bedside up the area, and we need to ensure that people aren't in the situation where someone with 7 diseases goes to 7 different clinics, potentially in 2 or 3 different places. We need to be looking for the common clusters of diseases and building services around them. But these are solvable problems. This is probably the most important slide that I'll show because I think it shows why I actually think we can do a lot better than that, however. This is the years in absolute life, that's the totality of the bar, and the years in poor health in the orange part of the bar. Now, the reason I want to stress this, and this may be obvious to many people in the audience, but it is not obvious to many people who comment, including in government, is that it is not inevitable that if someone lives longer, they will live for longer in ill health. Actually, if you look at this, the people who are in the least deprived areas both live significantly longer and have substantially fewer absolute numbers of years in ill health. And in areas of deprivation, the ill health extends into their working life at a point they're still caring for children. And so the effects are not only on themselves bad, but actually have an even wider ramification. Only, in my view, if we can shorten this period of ill health, do we have any chance of both bending the curve in terms of care needs, bending the curve in terms of the economic escalator, which OBR is correctly forecasting if we do nothing. And in my view, we can do that. Biologically, we know we can do that because if you live in an area of affluence, that problem is much smaller than it is elsewhere. Those issues are solvable. Now, the reason I think they're solvable is in part because we do actually have a natural span. And these are just pre-pandemic data. The light blue at the top is people in their 90s. We've not improved in life expectancy of someone once they reach the age of 90 for a while. And I don't think most people consider that's a particular problem. We have, however, substantially improved the life expectancy of people in their 70s, and I think most people would consider that is a good thing, and in the 80s is between that. Why does that matter? If there's an upper age limit at which our lives are naturally going to come to an end and we will all die, which is not a bad thing, it's just a thing, then if we can concertina all the disease as far to the right in time as possible, preferably beyond the point we're dead, that's the ideal, but if not, at least as much as possible, people are going to need much less social care, much less health care, have much better lives. Concertinaing this, shoving disease off to the right, because at a certain point, it's actually to the point you don't get it. If you live to 170, you would get, almost certainly, dementia and blindness and so on, but the fact is we don't. So if we can push things off to the right, we're not stopping things, we're delaying things, and by delaying, we may lead to people not getting diseases at all. It'll have a very big impact in terms of quality of life, but also impact on services. Third, slightly more optimistic point is I think there's often an assumption, including a kind of popular narrative, that once you get to your 80s, you can have dementia and you're going to be living in social care, and that's the way it is. The data do not back that up. Most people in their late 80s and 90s do not have dementia, are living independently, and have good qualities of life, and are very happy they're on this planet, and everyone around them is very happy they're on this planet. But there are people who also are living in pain, disability, and can see no way backwards from that. So my third sort of general point on this is, certainly my experience as a clinician, and I think I'm very confident if you ask most people at most high streets, if you say to most people, you're now 80, I can give you 3 years of life in disability with poor quality of life, a lot of indignity, or 2 years in good quality of life, which do you want? People should make their own choices, but I'm very confident, based on polling and other data, most people would go for the former. What does that tell us? Well, that tells us that what we should be doing is going for quality of life over quantity once you get to a certain point. Allowing independent choice for individuals absolutely should be their choice, surrounded by their family, but actually for most people, and much of medicine, if you do more, you will extend life, but potentially make life less high quality. That does not conform with where most people actually are in terms of what they wish. And I think we should be honest about this and say this very clearly to the public. Do you want us to go for always extending life at all costs, or do you want us to be principally aiming at quality of life? Because I'm very confident most people, not all, would choose the latter. Can we do this? Is it just optimistic? Well, I think the answer to that is clearly yes. When we put our minds to things, we don't do it quickly, you have to take a long run at it, that we can make substantial improvements on almost any disease state we have chosen to take on so far. So started off with infectious diseases. These are on the dotted line, for those who can't see because at the back. These are over about the last 100 years. This is what's happened. This causes a mortality, but it's also true for morbidity. Infectious diseases, huge problem even when the NHS was formed. I'm an infectious disease doctor. We largely did ourselves out of a job by the 1950s, except right at the extremes of age. Cardiovascular disease steadily increased to the 50s and 60s and then has been on a steady downward trajectory since that period of time. These are based on good science, properly applied. That's actually what's led to this. Cancer, the dashed line, is actually a combination of different diseases, some of which have improved substantially, some of which we are in basically stasis, and some of which will go up because of an older population. But those are the broad trends. Where the trend has changed, it has happened not by accident, but by design. We've worked out what the problems are, and we've attacked them systematically. Let me start off with cardiovascular disease. So these are going back to 1969, so 1970s essentially. Astonishing improvement in cardiovascular disease. It's made up of 3 components. And the reason I'm saying this, I think we can do this with almost every situation we're in if we're systematic. There's a group of things which are primary prevention. Government reducing smoking. I was delighted to see cost of smoking will go up in the budget. That is a good public health manoeuvre. And the differential with vaping, which we want people to move to, is maintained, a good thing. Measures like that, the bill which the Prime Minister has suggested to make a smoke-free generation, but also things like air pollution. I think people underestimate how big a risk factor for cardiovascular disease air pollution is. Again, I did an annual report on this a couple of years ago, and improvements in air pollution have also driven this. Several other primary prevention. A lot of the early improvements came from that. Then the second thing is secondary prevention, identifying at the earliest possible stage risk factors of early disease and intervening. Antihypertensives, people with high blood pressure, strict management of people with diabetes, statins for people who've got high cholesterol. And then finally, the bit that tends to get into the news but is actually probably no more than a third of the answer, is my view, an attributable fraction over that time. Much better treatments, stenting, movement away from surgery towards much more non-invasive patterns. Each one of these each intervention has probably contributed no more than 3 or 4%. Probably the only one that might have been more than that is aspirin, in my view. All the others are much smaller, but several 3 or 4, 100, 3 or 4% piled on top of one another, and you lead to these kinds of substantial improvements. The same is happening in cancers, but at different rates. There are broadly cancers which we can now treat, there are cancers we can prevent, there's cancers we can do both, and there's cancers we are poor at both as well. These are unpublished data, but which Cancer Research UK have kindly allowed me to show, On the left-hand bar, end of this bar is where the cancer survival was. This is about treatment back in the 1970s, and the right-hand end of the bar is where we are today. At the top of those are many diseases, particularly of younger people, but not exclusively. Extraordinary improvements in quality, where the majority of people living with those cancers, the vast majority, over 80% in some cases, will be alive and well 10 years later, who would previously have died. That is going to continue, but at the bottom of this graph are a large number of cancers where we've made very little progress indeed. And sadly, quite a lot of those cancers are the ones that are the most preventable. Lung cancer being the preeminent example, still by some distance the largest cause of mortality of cancers in the UK. Now, people often think this is due to some scientific breakthrough. Of course, it isn't. Science moves at an extremely predictable rate. If you look at, for example, colon cancer survival, melanoma cancer survival, I can do this with multiple cancers, and put a ruler on that, and guess where our survival will be in 10 years, you'll be pretty well there. Science moves at a particular speed. It wobbles around a bit, there's a bit of slowing in some of them, but in broad terms, it moves at a predictable rate. But it also moves at a predictable rate in the areas where it's going badly. Lung cancer being the most important numerically, and depressingly, of course, a cancer entirely for profit in over 70% of the cases, to make a small number of shareholders wealthy because poorer people smoke. Finally, of the big sort of three causes, blocks of disease, infection, there are definitely things we can do here. Again, science has an astonishing ability, when we choose to address infections. You just think about what happened in COVID, an infection of older people, and you can see where the vaccine came in. Sorry if there are any anti-vaxxers watching, but you can see very clearly where the vaccine came in terms of the mortality improvements, and the reason we can hold this meeting is because of our ability to address infections. So the idea that we cannot address these systematically by large numbers of scientific measures, some in public health, some in curative medicine, seems to me improbable. And we should be aware that infections remain, although often not the final reason people die, a significant cause of ill health and poor quality of life for many older people. I'm highlighting that because there are a lot of things we can do. Some of them are technological. You know, new vaccines for shingles, new vaccines for RSV are going to be major steps forward. Some of them are societal, better housing, for example, less damp, less cold, less mould. Examples of the kind of things we can do at a societal level. And then there are a small number of areas where we do not yet have a clear scientific answer, of which the most important is obesity. And I'm saying that because there's no country in the world, in my view, that has really got a phenomenally good answer to obesity, although some have got some form of an answer. But in the great majority, my view is we are making progress, and we will continue to make progress if we are systematic. So shrinking morbidity is possible, but it doesn't happen just by accident. It happens because of systematic approaches. So 3 slides just to summarize where I think we are. I think we have a very strong need to delay disease and treat it the earliest possible area, because that's what will shrink the orange bit of that bar chart I showed you, so people live with the shortest possible time in ill health, which is very good for them, good for their family, good for society, good for the economy, good for the NHS, good for social care. Everyone's a winner. And we can do that by being systematic about primary prevention, the things government can do principally, not exclusively, a secondary prevention, largely rooted in primary care, but not exclusively, screening and early diagnosis, and then treatment. And if we're systematic across the whole sweep, some diseases you can almost entirely prevent, can't easily treat. Lung cancer is a good example. Some diseases you cannot prevent, but you can treat if you do it well. Prostate cancer would be an example of that. And there are many where it's a combination of the two. But this is possible to do. Alongside that, shrinking so people are in a shorter period of their lives in ill health, we need to adapt the environment, particularly in the areas where there are very high concentrations of older people, so that people can maintain their independence for a lot longer with the same level of disability. And relatively modest adaptations can often lead to people, the difference between someone being lonely isolated, unable to engage socially, and actually having a full social life despite having predictable, moderate disabilities of older age. And many of these are harder, in fact, in rural areas, and we need to be honest about that, and we need to invest appropriately. But we know by looking at the maps where the problems will be greatest for those areas, and we need to, in my view, concentrate our efforts in those areas. So, finally, some key issues which I'd just like to add. Older age and deprivation are the two big drivers of where ill health is concentrated, and in the UK, they are now diverging geographically. In my view, the healthcare provision is going to need to reflect that, both in absolute terms, where general practice is, for example, and in specialist services, depending on what the routes are. Second, increasing multimorbidity means we must keep generalist skills throughout all the medical, nursing and other areas whilst specialising. I want to be clear, this is not an either-or, this is an and we need to have a much different approach, in my view, to research that recognises this. The major conditions strategy, for example, majors very heavily in multimorbidity. I think that is correct. I think this is an area we really need to take very seriously. Thirdly, age support ratios are going to move in a steadily adverse direction. That's not a guess, that is a certainty. As a certainty, and we have to design a service around that reality rather than hoping that somehow A, it won't happen, it will, and B, we can buy our way out of trouble. Almost certainly we can't. Fourthly, medical science will definitely help to shrink the impact of many diseases, but we should probably concentrate in particular, in my view, on diseases that cause disability and ill health for long periods in older age, rather than necessarily concentrating a very large proportion of our effort, our resource, towards extending by small increments life right at the tail end of a disease state. In my view, we should shift it up the curve. And the biggest one, which I really want to emphasise, is that shortening the period of ill health is realistic. There are lots of ways we can do it if we're systematic, but a lot of it is in the prevention space. And we cannot treat our way out of these problems. We can only prevent our way out of these problems. And the key to this is delaying disease. Some diseases you can prevent, principally infections or infection-driven diseases like cervical cancer, but the great majority you can delay, and if you can delay long enough, you get much less multimorbidity, shorter period in ill health, and you will probably live longer, but that's not the principal aim of it. Prevention is absolutely critical. In my view, without a very serious attempt, science-based on prevention, the NHS, given the numbers I put at the beginning, will struggle substantially. But I do think there is actually a way through if we take a long enough run at it. Thank you very much.
Thank you. Gosh, there was so much in there. I have several questions that I would like to ask, but I'm going to open it up to the floor because we have about 10 minutes and I don't want to hog it. Gentleman here, white shirt, right in the middle.
Thank you. I'm Liam, I'm a GP trainee. Firstly, thank you, a fascinating talk as ever. When it comes to delaying disease, I'd be really interested to hear your view on the sort of the relative importance between healthcare and the healthcare system and wider public policy, particularly around the social determinants of health. So if we're saying that if we do absolutely everything we can in healthcare to tackle this, are we going to shift the dial completely, or are we going to be sort of swimming against the tide of wider social and public policy? Thank you.
Thanks. Well, that's a really critical question. And I think within that, it's actually quite disease-specific. So I think people often try and make a general answer to what is actually not a general problem. So if I could go back to the examples I gave, in prostate cancer, you can do as much prevention as you like. Actually, it's not going to make any difference, as far as we can tell, at least at this point in time, with marginal difference. Whereas there are other diseases where it's an almost entirely preventable disease. If we dealt with air pollution, industrial issues, but above all smoking, lung cancer, COPD, a bunch of other diseases would fall away for practical purposes to be very small parts. They wouldn't go away completely. And then there are many diseases where it's a combination of those. And between the primary prevention end and the secondary prevention end, again, the ratios will vary depending on what the disease is and the current environment. But I think people often set this up as a false dichotomy, really. We clearly have to do the underpinning social determinants of disease, and they have wider use for other reasons as well. We clearly have to then target the particular health components of that, which include things like smoking and obesity, but many others, lack of exercise facilities. There are many others that go with that. Mental health, very much under-researched in that. And then treatment. But treatment is when the others have not done their job in many cases. For a large number of these diseases, and lung cancer would be absolutely preeminent amongst them, treatment is a sign of wider failure. We shouldn't have had to get treatment because, in fact, we could have stopped this or delayed it so much that it makes no difference upstream.
Okay. Lady over here, glasses.
Thank you. That was so interesting. I'm Julia Simon. I'm Director of Strategy and Partnerships at Homerton Healthcare in North East London. I'm really interested in your thoughts on what should the policy response be to the point around quality over quantity of life. When I joined the NHS many years ago, my father-in-law said, he was then much younger, of course, that at 80, there should be no more healthcare for people. NHS should be cut off, that's it, over and done with. He's now 93, and he's been grateful for the NHS. But also, in Sweden, where I grew up, there's this sort of mythical point around ättestupan, whereby people who are no longer economically active, can't contribute to the community, take themselves off and jump off a cliff, and that's the end of their life, and they choose that to support their local community. Quite drastic, both of those. What can we do as a modern, democratic, humanistic nation, policy-wise, recognizing that people do actually prefer quality over quantity? But what do you think is a rational or indeed reasonable response policy-wise to that?
Interesting.
The very interesting question. And I think I will give 3 immediate answers, but I think there's a lot we could do in that area, and I think we need to do it collectively. I think the first thing is we need to be really clear that the majority of people will choose quality over quantity and normalise that with the medical profession and others, but also make clear that individuals have individual choice. So if your father-in-law had taken a different choice, that choice would be respected, so that we're not trying to impose on people. But I think, I have seen a shift in my time as a clinician. I'm still a jobbing clinician. The expectation that if someone comes in and you can extend their life, you will extend their life, is now the default setting for the majority of physicians that I come across, which was not the norm when I was a junior doctor, actually. And I don't think that's where the society wants us to be. If that's where society wanted us to be, that's fine. But I think that shift has happened for a variety of reasons, not all planned. And I think we need to have an honest conversation, second point, led by society, not led by the profession. The profession can kind of say, professions can say, look, here's an issue. This has to be actually a societal decision, and societal decisions should be led by political leaders. So I think this is a discussion that needs to be had. We can make the general question, society then needs to answer it, and we need to respond. The third response, I think, is a research one. I think we have used longevity as the principal metric for a long time, and with hugely positive results. My first slide, in a sense, was the result of that. But I think what I'm saying is I think we've now reached the point where that is no longer the appropriate endpoint, and quality of life should be much more the principal aim. And then we accept we might get some extension of life as a result of that, probably will actually, but the quality comes first. Now, there are exceptions to that, childhood diseases, a variety of other things where I wouldn't want to make this an overall view in all situations, but I think it's changing the societal debate, and then following that through with the science and the practice seems to me where we should be heading.
Oh, I could spend all afternoon on that one. And the science practice. Lady here in red, then gentleman, I think Paul in the back there. So we'll just do those there. Yeah.
Hi, loved your talk. It was absolutely brilliant. My question is really about housing as well. Once upon a time, Christopher Addison, First Minister of Health, and now Bevan both had housing and health in their portfolios. And there's some evidence, certainly from nursing, that nurses will move to areas where there's cheaper housing. So if that's a kind of magnet draw, can we possibly accomplish, especially in, dare I say it, levelling up, with health without actually tackling the housing crisis?
Yeah, so I think again, I think housing has got multiple components, but I'll pull out three. First one, there is some housing that actually makes people actually ill, and that's the thing we should be dealing with first. But secondly, and very problematically, I think, for us, we are still predominantly building houses that are not designed for older people in areas of the country where all the growth is going to be older people. But the model is, and we should be having housing that is designed to be able to work through the entire life course, and that should be the design standard, rather than it's designed for a young family, and then you have to expensively retrofit it very inefficiently later in life when actually an older person is in that place. But the third one, which is the one you identify, we need to make sure, the reason why it's difficult to get people very often, for example, to work in coastal or rural areas is not because they're not beautiful areas, but difficult to get housing, difficult to get schooling, transport links are poor. The whole infrastructure is necessary. Just giving them an extra £1,000 a year is not going to solve those problems. Those are the fundamental reasons people are reluctant, and we have to be realistic about that and ensure that there is good housing for all price points throughout the system. But I think the third of those is actually the easiest to deal with. The first and the third, the middle one is actually the one which I think is the biggest worry I have if you project forward in places like North Norfolk or North Yorkshire.
Paul, middle gentleman, blue shirt, I think. Could be white, I'm not completely sure.
Definitely blue, thanks Thea. Paul Farmer, Chief Executive at Age UK, and also a non-exec here in Frimley, where we all are. I would just like to say Frimley isn't all like this. Chris, thank you very much. It's a brilliant report, and thank you for what you're doing in this space. You propose some quite radical policy shifts, actually, in the report. How long have we got before this moves from being something we are thinking about to something that becomes a major crisis for the NHS and indeed wider society?
Well, I think many of the things that we're struggling with now were predictable 30 years ago, and we all wish that the people 30 years ago had gripped them, but they didn't. My view is our successors in 30 years will not thank us, because these trends are not a guess, they're a certainty, and we need to be taking a serious run-up at them. The closer to the time you have to do it, housing as an example, the more expensive and difficult it's going to be. So I think we should be really aiming to change the policy directions at this stage, where many of the benefits will be in the longer term. Now, that requires a different approach from Treasury and many others, and I'm trying to have those conversations in government. But we do need to actually, in my view, be serious about particularly capital investment now that will help us in the long run to head off these problems and to soften the blow when we get there, because we'll really regret it if we don't.
Can I just ask a question while I'm here? Which is, if we do that, do we run the risk of moving money away from the inner cities where we've got a different sort of poverty and a different sort of deprivation, which you demonstrated, say, by the infant mortality? If I'm running an ICS and I've got an inner city and I've got rural areas, and I'm listening to you and I'm thinking, oh my goodness, I need to get my money out to the coast, am I running the risk of depriving the deprived?
Well, I mean, I think ultimately you're going to have to try and divide your resources between both of them.
Yeah.
My view, though, is that you're going to need different resources in different places. So you're going to have to build up a lot of your resources for prevention of cardiovascular disease and mental health, for a variety of other things in the urban centres. You're going to have to build up your resources for people having mobility issues, for housing issues, for stroke centres out in the periphery. So what you're not going to want to do is spread the whole thing evenly, but just concentrating on the areas of deprivation, I think, ignores a very large and growing part of the medical work and social care work we're going to need, which is in the older population. And the areas of deprivation are going to get higher or lower based on the economic cycle, but they're going to stay roughly where they are at the moment, because that was the point I was making, is where they are, and they are depressingly static. The areas of growth in the other areas are largely going to come from the areas of older populations. Yeah. And I don't think we're planning for that, but I think we need to.
Yeah. Gentleman there, blue, Alex, I think it is. Yes, it is. And then I'll go back and look at the other side of the room.
It's Alex Fox from Empower and NHS Assembly member. I completely get your point about quality of life. I'm just very conscious that if we're going to have that discussion about framed in quality of life, that for disabled people, people with learning disabilities, people with mental health problems, face huge prejudices, often framed in assumptions about people's quality of life. So it makes logical sense. It's also incredibly dangerous for quite a large section of the population. So it just feels like it's a dimension to that discussion that really needs highlighting. And it gets into your inequalities point, where actually the quality of life of somebody with a learning disability, for instance, might be hugely predicated on the quality of and investment in social care in that area and the inclusiveness of their community, which is obviously non-medical factors. So it just feels like we need to bring that into that discussion at every point.
I completely agree with that. Quality of life should be defined by the person whose life it is, not by anybody else. And I think that covers both areas of this. But I think the danger is people, because of that concern, have shied away from the wider point, and I think we should stop shying away from it. It's an issue which I think we are going in one direction and the public is in a different place, and I think we need to bring them back together again. It's not in anyone's interest for us to have this divergence.
Okay, over there, my line of sight, and then I'll take one more question and then we're going to have to...
Thank you.
Lady behind as well. I can see her, just see the hand there. Yeah, okay.
Thank you, Thea, and thank you, Chris, for an excellent talk as well. Obviously, Chris and I know each other very well in terms of pandemic preparedness. For those of you who don't know me, I'm Kate Arden. I was Director of Public Health in Wigan and one of the folks involved in developing the Wigan deal. I'm now retired from being a DPH, but I'm doing many other things in terms of national policy advice, working with Reform, with Lord Filkin and with other folks. Lord Filkin's team are particularly looking at prevention policy for the first 100 days of a new government as well, which is quite interesting. My question, Chris, just thinking about looking at your geography in particular, and I guess it follows on from some of the other questioners' points to you about housing and social determinants. One of the challenges over the next 20 and 30 years is climate change adaptation and mitigation. And many of the areas where the older population are moving to are actually going to be areas that are going to be particularly vulnerable to the impacts, for example, of flooding resilience. I'm doing some work with the British Academy and Wellcome Trust on the health implications of that at the moment. But have you factored that in? Because obviously environmental adaptation will impact on geography and therefore will impact on people's ability to move out of cities to coast. They might actually start moving back.
Yeah, thanks very much indeed, Kate. And the answer is, I mean, I have quite looked a lot on climate change, actually. My view is it's a mistake to try and weave everything into everything because you end up with a mess of porridge that is impossible to do something about. There are a bunch of things we need to do on climate change, some of them which are about flooding, as you say, coastal, pluvial, all the different forms, some of which are about higher temperatures in summer. You can see the spike in the mortality from the heat waves 2 years ago really clearly in the data. You don't need to struggle. It's obviously they don't even need AI. You can just see it. So there are a bunch of things that we need to do on that. But I think it's a mistake to, because one of the things I worry about in public health, and I've seen this quite a lot actually, is people saying, well, you can't do that because it doesn't deal with this, and this. To which my answer is, actually, let's just get on and do all the various things we can do along the channels. Stop using that as an excuse for not acting in the areas that we can work in. I'm not saying you do, I'm just saying, in general, there is a real risk of us always using all the other problems as the reason for not acting on the problems we can deal with, and we want to avoid that. But I completely agree with on climate change, and we are going to have to deal with it. Of course, in many other parts of the world, it's on us a lot earlier. Sahel, for example, or many parts of Asia, we're already in serious trouble. UK will be later because of where we are geographically. That's an issue of geography rather than anything else.
Okay, last question from this lady, yes.
Thank you very much. Chris, that was a fantastic lecture. Thank you. I'd like to draw from the 3 points that you raised with the key issues. The first is that with increasing multimorbidity, which means we must keep generalist skills as we specialize and have a different approach to research, as well as delaying disease for as late as we can. What is the plan? And you emphasized a lot on systematic approach to planning and making sure that something is in place. Otherwise, in 30 years' time, they will not thank us for doing nothing about this. What is the plan for medical students as well as postgraduate doctors to have either preventive medicine or lifestyle medicine or both in the curriculum, so that we are training a core critical mass of healthcare providers to tackle this? And by the way, my name is Ifeoma Monye. I'm Regional Director for South Central England, British Society of Lifestyle Medicine. So I'm quite biased towards that. What is the plan for doctors, nurses, physiotherapists, and physician associates and so on to be equipped to help the populations? Thank you.
Thank you. I think that's many people in this audience, of course, will have had the privilege of being part of curriculum discussions in nursing schools, medical schools, and whatever, and be aware that everybody wants to do more and nobody wants to drop their area. I have from my own medical school days, I can remember at least a third of the curriculum, which is, and will always be utterly useless for me. But come on, someone clearly fought for it. This is an area which we absolutely must prioritise, in my view. Multimorbidity and generalism, I think we're still in the process of a debate within the medical profession, but I actually think almost everybody now agrees with the general point. We've, I think, now got to the stage in medicine that every specialty agrees that every other specialty should keep its generalist skills, but their own is the exception. That's progress. We now need to get to the point where everyone just accepts this is across the board, and then I think we need to make sure the medical schools follow suit. I'm sure the same is true in the other professions. I can speak most clearly for medicine. But on the prevention side, my experience of the teaching that goes on in general medical courses is I don't think we collectively teach it well, actually. I think we teach it as a set of problems, but we don't teach it as a set of solutions. And I think we should be much more clear that this is an important part of every trainee, whether they're a doctor, a nurse, a physio, all these areas. People can learn systematically how to reduce the risk of future disease. And even within general practice, you sometimes have a bit of a debate about should prevention be a major part of general practice. That seems to be a self-answering question, but it isn't for everybody. And so I think we should be really clear that this is an area which this is the only way, to go back to my last and, in my view, my most important point, the only way we can address what is otherwise an inexorably impossible problem to solve is by us taking the whole prevention side a lot more seriously, and that's got to start right at the beginning of training, because that sets the foundations for people's thinking.
Thank you. Well, thank you very much. We've come to the end of what was an amazing session. I'm not going to try and summarise it. There's an awful lot for us all to go away and think about. If we can just get the curriculum right, if we can just change society's views on everything, if we can just think about the way we allocate our resources, maybe we're not all going to be doomed.
No, I think it's doable.
And he thinks it's doable. So thank you very much. Yeah.